we'll talk about eosinophilic esophagitis today. To be honest, my talk, I can summarize my talk in probably 2 or 3 sentences. It's not very much sophisticated. In a nutshell, as it's known, eosinophilic esophagitis, the main symptom would be dysphagia, mainly to solid foods. The symptoms are mainly during the meal. Okay, it's very remarkable. There are other symptoms, but dysphagia would be the main symptom. And it has got complications, so it starts as an inflammatory condition, and then it can pass on to fibrotic stage. The main investigation would be endoscopy and biopsies, and there's no diagnosis without biopsies. The hallmark of it is eosinophils more than 15 per high power field, and this distinguishes it from many other esophageal diseases that would cause esophageal eosinophilia. And the treatment is PPI, topical steroids, dietary restriction, if at all possible, and management of complications. And this would be mainly endoscopic. That will be discussed by Prof. Motaz. We'll start the talk now. So eosinophilic esophagitis, sounding sophisticated, but it's a chronic immune antigen-mediated esophageal disease characterized by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. So it's an inflammation that can pass on to fibrosis, but actually the eosinophils can go to other layers of the esophagus, the inner layers, causing a bit of esophageal dysmotility as well. So inflammatory with predominant eosinophilic inflammation, progressively fibrotic. Epidemiology, well, these numbers are, I don't know if you can see my cursor, mainly in the UK, 63 every 100,000, more common in males. It's mainly a disease of younger people. So in children and young adults, okay, peak at the 3rd or 4th decade, but it can happen in all ages, actually. Our main discussion here will be in the adults above 18, but there will be a hint about the children as well. It can accompany atopic diseases such as allergic asthma, rhinitis, and eczema. The complication of food bolus is the most frequent emergency. Sorry, I'll have to do this to see the rest of my screen. Most common emergency presentation of eosinophilic esophagitis in 20% is the most common cause of acute food bolus obstruction seen in emergency departments. Okay, there is seasonal presentation, and this could be because of the seasonal availability of the foods that can trigger it, but also there are environmental factors. Okay, there are subtypes, but I mean, I'm not sure how useful it is to know the subtypes. There's a mild type, there's an inflammatory type, and there's a fibrostenotic type, grading from better to worse. Okay, so the clinical manifestations in adults, it's dysphagia to solid foods. It's the most common symptom. And up to 15% of patients who present with dysphagia, well, especially in the young, it will be eosinophilic esophagitis. There can be a history of food impaction in 54% of patients. It doesn't have to be when they form a stricture. It can happen with the inflammation as well, because of the inflammation, and there could be some dysmotility problems as well. Stricture formation in up to 10%. And the symptoms vary. It can be very mild, intermittent, just very occasional, sort of grading up to forming strictures, having significantly affecting the quality of life. There would be significant discomfort or difficulty in passing food during the meal. Now, this can help, although not really, this can help differentiate between this and the gourd, the gastroesophageal reflux disease, where gourd mainly tends to cause symptoms postprandially. But come on, none of us would be able to actually differentiate it clinically unless you probably do an endoscopy and see what's happening in there and take the biopsies. But it's a hint that's suggested by the frontline gastroenterology. Sometimes when there's a food impacted, they can have water coming into their mouth, which would sound like reflux, but no, it doesn't. It doesn't taste like acid. It's just because they can't swallow their own saliva sometimes because of the food infection. Other symptoms might be chest pain, might confuse you with gourd. It's the most common cause of spontaneous rupture of the esophagus as well. Okay, whether with food infection or without food infection, because the mucosa can become quite friable, what we call crepe paper mucosa. Symptoms in children, well, it's not focused on children, this talk, but dysphagia, again, food infection, they can have vague symptoms, the children. Difficulty swallowing, vomiting, abdominal pain, slowly eating, and you'd have to suspect it, things like that. Both the inflammation and fibrosis contribute to the obstruction of passage of food. There's a strong association with allergic rhinitis and other atopic conditions, and it's a common cause of dysphagia in atopic school-age children. Diagnostic criteria, again, the dysphagia, symptoms of, related to esophageal dysfunction, is eosinophil predominant inflammation on esophageal biopsy, more than or equal to 15 eosinophils per high power field, exclusion of other causes. But the other causes are less common, and mostly they would not have the eosinophils more than 15. And again, the distribution of the eosinophilic esophagitis, it's usually patchy and would include the whole esophagus. The gourd, for instance, is not that patchy. It would not include the whole esophagus. The gourd is more towards the lower end of the esophagus. Things like that, you'd think about it, and the histopathologist will hopefully help you. So eosinophilic esophagitis that will respond to PPI is called PPI responsive esophageal eosinophilia. Okay, it's now considered a subset of eosinophilic esophagitis. Gourd and eosinophilic esophagitis can coexist. So sometimes you need to differentiate between them, but sometimes they coexist. But come on, you're going to give a PPI anyway, and you're going to do the endoscopy anyway if you're see the endoscopic picture and take some biopsies. And the investigation is endoscopy and biopsies. Should be 6 biopsies from different regions in the esophagus. You look at the endoscopy, patient with dysphagia, even if the endoscopy is normal, we're going to biopsy anyway. Yes, there is a picture for eosinophilic esophagitis, but it might be entirely normal, and especially if if they've got dysphagia and there's normal esophageal appearance on endoscopy, biopsies. 6 biopsies, how you want to distribute it, either take 3 from the lower, 3 from the middle, 2 middle, 2 lower, 2 upper. We don't feel comfortable taking biopsies from the upper esophagus. Well, probably 3 in the lower half, 3 in the upper half. See what you want to do. 6 biopsies in different zones in the esophagus. Endoscopic appearance, how I remember it is horizontal, vertical, and spotty. So stacked circular rings, okay, this is transient. The feline esophagus is transient circular rings. Trachealization looking like trachea. Rings are so much accentuated, eventually progressing to strictures, now being narrow with fibrotic element. Linear instead, linear furrows. Attenuated vascular pattern because of the edema. Whitish papules representing eosinophil microabscesses, small caliber esophagus, and they can have normal esophagus. This is the feline esophagus, circular esophagus with microabscesses. This is trying to form into a stricture now because it looks a bit fibrotic, and probably this is more narrowed than usual. These are the linear furrows, and these are varied pictures. So I would say this is the trachealization, I would say. This is the trachealization, looking like a trachea. These are the exudates, okay? This is crepe paper esophagus. Now it's very fragile. It tears very easily without significant endoscopy trauma. These are the transient rings, again, okay? That's all. Histology is very important, more than 15 per high power field, 6 samples are needed, biopsies from different regions, and always in a patient with dysphagia, biopsies, biopsies, biopsies. Okay, now eosinophilic esophagitis and gourd, they can coexist. Gourd is mainly in the lower esophagus, will not reach more than 15 eosinophils per high power field. That's all actually. Okay, eosinophilic esophagitis tends to be patchy. So look at the history of atopy in eosinophilic esophagitis. Okay, when symptoms occur. Okay, so after meals with gourd, but during swallowing with eosinophilic esophagitis, endoscopically and histologically. Okay, different causes. So I eat chocolate. I eat. I'm fat. I drink a lot of coffee. I smoke. Okay, but I'm atopic. That's a different story. So just clues, and they can coexist, especially in children. Okay, there are other common eosinophilic pathologic features in both, but the number of eosinophils and the appearance should show. There could be underlying milk allergy in eosinophilic esophagitis with children, okay? And they will both be treated with a PPI. And if we're not sure, we're gonna do an endoscopy. But of course, in children, we have a higher threshold to do an endoscopy. But if it's affecting the child, then okay. So there are some diseases that can have high eosinophilic count in the biopsies, but these are less frequent, as Chagas disease, achalasia, hypereosinophilic syndromes. But there are other clues to tell you whether it is. So they're less common as well, and most of them do not reach more than 15 per high power field. Sorry about that. Okay. Any blood tests for eosinophilic esophagitis are not helpful. Not immunoglobulins, okay? Not the eosinophils, they are not sensitive. And tests for the skin are not sensitive. The only time when they are helpful, the skin tests, are with children. When we are trying to find out which foods they are atopic to. Otherwise, the skin tests are not related to the eosinophilic esophagitis themselves, and they are not useful in adults, because in adults, it is not IgE mediated, it's actually IgG. In children, it is IgE mediated. So probably would give you a clue on what foods you try to avoid in children. They're less helpful in adults even. And there are foods that you're gonna try and avoid anyway if the patient agrees, and that's the main thing. Management is, as we said, PPI, okay? Give it 8 weeks. If you wanna start with the 40 milligrams once a day for 4 weeks and then escalate to 40 twice a day for another 4 weeks, that's fine. If you wanna start high dose for 8 weeks from the start, that's fine. And assess, okay? Always assess not only with the symptoms, but with endoscopy as well, okay? So the symptoms can be misleading because of how the patients can adapt as well, okay? Always do an endoscopy and see the response. If it's not responding, go to the topical steroids. When are we gonna do the food elimination? You have to discuss it with the patient, because the patient is it's gonna affect their quality of life. Okay, when do you start the food elimination? We probably will start the PPI anyway. And then you start to think about it if the patient is not really responding, especially if they had topical steroids and they're not really responding still. And of course, you're going to discuss food elimination if they start to get the complications and fibrostenotic diseases and things. And what foods we're gonna eliminate, that's for discussion. And then the endoscopic treatment for complications, we're not going to discuss this. It's on the next lecture. Optimal approaches. So there's no optimal approach, to be honest. What is what? But that's the well-known practice that we all do. But there's no guideline actually on how exactly it should be. But this is the well-known thing. Okay. So PPI, as we said, let's give it 8 weeks. Okay, and assess after 8 weeks. Put a questionnaire for dysphagia. Okay, so symptoms and endoscopy, both, always for response. Okay, if gourd coexists, it will help as well. Okay, so if it's not responding, then go for the topical steroids. And this is the fluticasone, which is the patient will not inhale, they will swallow instead, 2 puffs twice a day. And then there's the oral dispersible budesonide, and always do histology after this. And the only UK accredited one is the oral dispersible budesonide, 1 milligram BD. Okay, so meter dose inhalers to swallow, not to inhale. Okay, highly effective, can cause oral thrush. Okay, topical steroids to continue for 3 months. Okay, and then to see the response. If they're not responding, consider maintenance, consider dietary elimination. Okay, elimination diet is 2-4. We start with 2-4-6 elimination. So you start. So the most common are milk, eggs, soya, wheat. Okay, fish, nuts. There are others which are legumes, but they're usually 6. You start with 2, and if there's no response, you give it 4, and you always assess with the patient's symptoms and the endoscopy. And it gets harder as you restrict because it affects the patient's quality of life. Okay, in children, it's more effective because you're more timid to give the steroids in children, but you're gonna try it. It can be a bit challenging with the adolescents as well. And it's always, you start with restricting the cow milk. Okay, and it's for well-motivated patients. Okay, allergy testing will play a role in choosing what type of food to eliminate from children, but it's not really helpful in the diagnosis of the condition, and it's not helpful in adults because it's not IgE mediated. Food elimination will have to be very well discussed with adults. If the patient has got food impaction, fibrosis complication, consider maintenance, steroids, and discuss food elimination always, and you're gonna manage with endoscopy. Complications, as we've said, food bolus obstruction, most common causes is Inophyllic esophagitis. Management is endoscopic, but take care with food bolus. They can have spontaneous esophageal perforation. Take care. Chest pain, crepitus on the neck, surgical emphysema. Do a CT, cover with antibiotics, keep nil by mouth, and see. Okay, but if it's food impaction, endoscopic management, with which Prof. Motaz is going to speak about. Most common cause for spontaneous esophageal perforation is eosinophilic esophagitis, severe chest pain. This can happen with food impaction or without food impaction, the spontaneous esophageal rupture, stricture, or a wide bore esophagus, narrow bore esophagus all through the esophagus rather than a localized stricture. And this will cause significant dysphagia and will require repeated endoscopic intervention. A narrow bore esophagus all through. Okay, this is one of the complications of esophageal eosinophilia. Maintenance therapy, namely actually with topical steroids and dietary elimination in severe dysphagia, food impaction, high-grade stricture, rapid relapse following withdrawal of treatment, and this would be with dietary and topical steroids. And thank you. I'm done.
Thank you, Dr. Inji, for your update lecture. Please stop sharing the screen, and we will proceed to the next speaker, Professor Dr. Mu'taz Zeyad, and his talk will be about the cons and pros of endoscopic management in case of eosinophilic esophagitis. His talk will be in the form of questions and answers, and please start sharing your screen, Dr. Mu'taz. First question to Professor Dr. Mu'taz. For which phenotypes of eosinophilic esophagitis dilatation is indicated?
Welcome all. Thank you for the society and for Dr. Serag and Dr. Shireen to be here. We wanted to see you with us in the conference second year, not on webinar. We adjusted the lecture with Dr. Shireen, that is a question and answer about endoscopic treatment of eosinophilic esophagitis. She will be short and concentrated, inshallah. The first question from Dr. Shireen: for which phenotype of eosinophilic esophagitis dilatation is indicated? Whatever, as Dr. Inji said, there are many phenotypes of eosinophilic esophagitis. It is sometimes difficult to detect. However, the majority of others with this condition, 95%, well presented with dysphagia, as means they have stricture, and then sometimes we will need dilatation. That means if you diagnose eosinophilic esophagitis, it is not necessary to detect the phenotype to detect the prognosis. Still, there is a work to do. When I see eosinophilic esophagitis, prognosis will be stricture or not. Is treatment will prevent stricture or not? The question until now not answered.
How is esophageal dilatation performed? Is it performed using balloon dilatation or Savari, Dr. Mohamed?
As a rule, esophageal dilatation can be managed as any structure in the esophagus. What it means when I decide to dilate esophageal structure, I see it is long, short, where it is present, how tight is it, and I decide the technique I will use. Whatever the method which I have access for it, expert for it, I must use. Some places there is no Savari dilator, so I will use a balloon. But if I have all the accessories, for all of them, I choose the balloon for short structure, tight structure, and I will use Savari for long structure, complicated one. For the balloon dilatation, as we see, we do the endoscopy and detect the size of the structure. Then I pass the through balloon dilator. First, I will introduce, as you see here, to the structure. Then I inflate the balloon. The balloon diameter will influence it by the pressure I put inside the air inside it. Usually, she covers three diameters, means 10, 11, 13 French. Some of the endoscopists inflate the balloon distally, then pull up through the structure. So she can use it as a Savari. As I see, it is nice.
This is better. Now the voice is better.
This is better. This voice is better. When I use a balloon dilator, I use a structure which is not long. I introduce the endoscope, and through the endoscope, I will introduce the dilator balloon. Then I inflate it. The balloon usually will cover 3 diameters of dilatation. 10, 11, 12 range. This is regarding the pressure I put inside for the air. Some endoscopists use the balloon as a Savari. How? She will just inflate the balloon here and pull it through all the esophagus. So it is dilated to the diameter there. It's a very dilated. Very dilated, as we see, 1, 2, 3, all of them have fixed diameter. She passing the long tube set and the fixed diameter. She will firstly I will pass the Savari guide wire inside the stomach. Then I will post the Savari over it. I choose the one which just pass. Then I proceed to the one more widened, more than widened. Usually in every time of dilatation, I use one after I feel resistance. That means I not use all of them. مثلا if I feel resistance with 11 French, I just will introduce 12 French also.
And now the next question is, what is the defined esophageal diameter to be targeted by dilatation, Dr. Mohamed?
This is an important question. If the patient has tight structures, I must not dilate it to the target I will choose. The normal persons will not feel dysphagia except the esophageal diameter less than 15 millimeters. So if patient have tight structure around 9 millimeters, I not need in one session to reach 16 or 18, which is our target. I will just, in one time, I will use 3 dilators that reach 12. Then the second time I reach 15. Then third time I reach 18 millimeters. This will do gradually.
Is there any benefit of one type of dilation over the other in cases of eosinophilic esophagitis?
Every endoscopist or every centers have his preference for one type. But no study, no head-to-head comparison has been conducted to conclude that One method is better than other. But it is, as I said before, it is operator dependent. If you experience, we use the balloon, use the balloon. If you expert, we use the Safari, use the Safari. Right. As we said, if the structure is narrow and not long, use the balloon. If the structure is long, use the Safari.
What are the common side effects of dilation in esophageal esophagitis?
As all of us know, the day which you have a case of dilatation, you, you think it is not a good day. Perforation is not common. It is occur less than 20%, 2%. But if you not use much dilatation at the same time, use it carefully. This will be the percent, 2%. If perforation occur, not panic. Most of them use with conservative measures, it is relieved. Conservative measures means nothing per oral, admitted to the hospital, fluids, antibiotics. Some of them will need to put stent, covered metallic stent to help the situation. The other complication besides perforation is chest discomfort and pain.
How can we avoid these risks of perforation?
Careful is the clue. First, the procedure needs to be performed carefully because this patient presented with a lot of scarring and fibrosis, and they should to do it carefully. Second, dilation should be gradual procedure rather than an aggressive procedure. For example, if the patient have a very narrow esophagus, he or she generally should not be dilated to a normal esophageal caliber in the first session. If it is very tough structure, he may need many sessions.
Does the dilation method affect the rate of perforation? Is it more with the balloon dilator than the Safari?
Papers said that Safari dilatation may be slightly riskier than balloon dilatation. But there's a trick here, that the Safari is used in long structures. So maybe this statistics because the Safari used in more difficult situations than balloon. So perforation occur more when Safari. Next slide. Just a minute.
Yes, we will. Yes. Just a moment. Dr. Mu'taz will fix a technical problem.
Okay.
Dr. Mu'taz, there is no difference between the balloon dilator and the Safari dilator regarding the risk of perforation, right? This is the message you want to say?
All the papers done shows that it's riskier to do Safari. But by the fact, we use the Safari in the more complex and difficult cases.
Yes.
So by default, there will be more perforation with it.
Yes.
But if we use the same, the short, narrow structures with Safari and with balloon, most probably there will be no difference.
Yes.
If you are experienced with the Safari, use the Safari. If you are experienced with balloon, use the balloon.
Very
good. You mentioned at the beginning something about longitudinal
narrow structures.
And multiple.
Yes.
40 or more years ago, we were cooperating with cardiac surgeons, and we used to do retrograde. Dilate direction and go retrograde through the cardiac, it's more safe. But because it is stacked and no problem, we tried it.
Okay.
So Dr. Mu'taz,
can I have a question, please?
Yes. Are you waiting?
yes, please ask, Professor. Dr. Ashraf Abu Bakr, I think he's asking a question.
سؤال دكتور معتز. How can we diagnose a xenophilic stricture from a patient that come to us with a stricture? How can we diagnose this is a xenophilic stricture to be cautious during dilatation compared with other stricture?
Just Dr. Engi can cover this situation just by biopsy to see there is eosinophilic infiltrations and the diagnostic criteria done before. But as a rule, strictures must be we do barium before and we'll do endoscopy and take a biopsy. But no difference. The risk of perforation, as we will talk after, is not different between eosinophilic or other causes of stricture. Before many years, we think eosinophilic esophagitis more risk to rupture.
Yes, because some patients come to us with a stricture without diagnosis. Should we take a biopsy from any stricture or just do a start by dilatation?
Usually we will take because we are afraid that is malignant stricture.
Okay.
Thank you.
What are Dr. Mu'taz, can we do this dilatation in the pediatric setting?
Yes, we can do it in a pediatric setting, no different at all, but usually children not have tough stricture. Usually they started to, when he gave a teenager, they started to develop strictures. And their dilatation is not risky as adult. Yes. Perforation is much less than that before.
How common is the need for subsequent esophageal dilatation?
You said the patient, we will need many or several dilations because as a rule, it will be recurrence many times. 100% when you dilate patient with eosinophilic esophagitis, he will reverse it to have dilatation again. When the difference, if he take medication, he avoid diet, this will delay the problem. Patients which have small caliber esophagus or tough strictures will need, most probably we need more session and will have recurrence many times.
Does the dietary and medical therapies reduce the need for any follow-up dilation?
This said that corticosteroid and the dietary therapy reducing the need for subsequent dilatation, but if it improves the histology. If it improves the histology, means it will take a benefit. If we do that and no improving for the histology, we will not get a benefit. This is a logarithm about the management. As a rule, we start to try topical steroids and the dietary treatment. If the stricture is not tight and do not affect the feeding of the child or the taking food of the adult. If it is tight, we start by dilatation. If it is tight, we do start elemental diet with systemic steroid, then esophageal dilatation.
In dilatation therapy, yes, we asked this question already. What are the long-term outcomes with the dilation therapy?
The big questions. No one follows the patient for 10 or 20 years after starting the dilatation. Said many dilatation, making trauma and more scars. That means as the patient have a long time, you have high risk of perforation when you dilate him. But we have no good evidence for that. We need more studies in that. Thank you.
Thank you, Dr. Mu'taz. Dr. Serag.
We thinking about that, not written, but if patient have very long strictures, his health is not significantly supported to do esophagectomy and pull off the upper of the stomach, since it will be not FDA approved clue.
And now I would like to present a case of chronic diarrhea. This case is a real-life case of a female patient, 45-year-old, presented in the outpatient clinic. Do you have the screen? Can you see the screen? Yes, she's a 45-year-old presented in the outpatient clinic complaining of chronic diarrhea of 1 year duration. She reported passing loose stool 3 to 4 times per day associated with abdominal pain. She also reported having occasional bloody diarrheal motions over the last 2 months and no weight loss. There was no fever or skin rash, and the patient gives history of allergic rhinitis since her adolescence. Her physical examination was unremarkable. The investigations showed microcytic hypochromic anemia, hemoglobin 10 gram per deciliter. The total leukocytic count was within the normal range, but the eosinophilic percentage was higher than normal. It was 5%, while the upper normal range is up to 3%, with absolute count 650 eosinophilic millimeter, while the normal range is up to 500 cells per cubic millimeter. The ESR was mildly elevated. It was 23 millimeter per hour. The CRP was 5 milligram per liter, and the fecal calprotectin was 65 microgram per milligram. Other investigations were done. Anti-tissue transglutaminase immunoglobulin A and total immunoglobulin A were normal. Liver, kidney, thyroid functions were normal. Viral hepatitis C, B, and HIV were negative. Parasitological examination and bacterial culture of stool were normal, and there was no remarkable features in her abdominal ultrasound and chest X-ray. We proceeded to do the colonoscopy, and ileal intubation was done, which revealed hyperemic mucosa of the cecum and descending colon, with almost normal looking mucosa of the rest of the colon and terminal ileum. And multiple biopsies were taken for histopathology. The pathological examination revealed increased eosinophilic infiltration and picture of suggestive of eosinophilic colitis for clinical and endoscopic correlation. We were not satisfied with the diagnosis, so we referred the patient also to an immunologist who recommended further tests. He asked for immunoglobulin E, which was higher than normal. It was 191, and he asked for allergen-specific immunoglobulin E test, which showed elevated immunoglobulin E against peanuts and fish. What we did is we revised the pathological examination of the colonic biopsies and asked for eosinophilic count in the samples. It reported mildly distorted glands with markedly increased eosinophils per high power field, more than 40 per high power field in the lamina propria, and there was no parasites seen. Picture suggestive of eosinophilic colitis. The patient also underwent upper GI endoscopy, which showed erythematous and edematous mucosa of the antrum, bulb, and descending duodenum, and the histopathological examination of the biopsies taken from the stomach and duodenum again revealed increased eosinophilic infiltration more than 20 per high power field. This patient was started on oral prednisolone, 0.5 milligram per kg per day for 4 weeks, and then tapered over other 8 weeks. With this treatment, the patient's symptoms regressed, and upon follow-up, she noted improvement in her bowel movement with formed stool. Her repeated blood tests showed improving eosinophilia. It dropped from 5% to 3.5%, and otherwise, she did not experience any adverse effect of steroids, and she was diagnosed as a case of eosinophilic colitis for follow-up. This is the end of the case presentation, and we hope we will learn more about this entity from the next speaker, Dr. Mohamed Hassan, and his talk will be about the updates in diagnosis and management of eosinophilic gastroenteritis. Dr. Mohamed Hassan is an associate professor of internal medicine, gastroenterology, hepatology, and endoscopy at Ain Shams University and Ahmed College of Medicine.
Hello, Professor Shireen. Can you hear me? Yes.
I will start sharing the presentation now.
Good afternoon, everyone. Can you hear me well? Good afternoon. Good afternoon. Can you hear me?
أيوة Hassan, proceed, yes.
Okay.
Yes.
Okay. So our agenda today will be speaking about the eosinophilic gastroenteritis. We will start with definition and incidence. We will go through types, theories, diagnostic criteria, differential diagnosis, and management. First of all, we will give some highlights on eosinophilic gastroenteritis. Eosinophilic gastroenteritis is defined as an inflammatory disorder that is characterized by eosinophilic infiltration of the gastrointestinal tract. Its prevalence in the United States is 8.4 to 28 cases per 100,000 in people aged from infancy to the 70s. We have three types of eosinophilic gastroenteritis. The first type is the mucosal type, which affects the mucosa. It's the most common type and it represents 60% of cases of eosinophilic gastroenteritis. Usually presents with abdominal pain, nausea, vomiting, and malabsorption features. Those include hypoalbuminemia, anemia, weight loss, and sometimes there might be colonic bleeding. The second type is the muscular type. It represents 30% of the types of eosinophilic gastroenteritis. It might present with bowel wall thickening, intestinal obstruction, or obstructing fecal mass. The third type is the serosal type, which represents 9% of the causes of eosinophilic gastroenteritis and usually presents with eosinophilic ascites. We have multiple theories for the eosinophilic gastroenteritis. This includes the hypersensitivity theory that is supported by the association with other types of allergies. Also, 60% of the participants may have family history of atopy. Another theory states that it might be an autoimmune disease, and this is supported by its association with other autoimmune conditions such as ulcerative colitis. The third theory implements that there are environmental factors such as parasites and drugs that share in the etiology of the eosinophilic gastroenteritis. Also, it's sometimes associated with functional dyspepsia. Now, we proceed to the diagnosis of eosinophilic gastroenteritis. The diagnostic criteria include the presence of gastrointestinal symptoms, the presence of eosinophilic infiltration of the gastrointestinal tract or presence of high eosinophil count in the acidic fluid, such as in the serosal type, as we explained before. Exclusion of other causes of tissue eosinophilia. We have to exclude the differential diagnosis in order to proceed. So in our way to make the differential diagnosis, we have to check for the presence of intestinal parasites. We do this by stool test. We do stool analysis for ova. We have to check that there is no eosinophilic esophagitis. We know the clinical picture as Professor Mohamed explained. It is limited to the esophagus, and usually there are ridges and furrows in the esophagus. We have to exclude other causes of ascites when we have eosinophilic ascites, and this is through the acidic fluid cell count. Usually in eosinophilic ascites, there are more than 90% eosinophils. In case of celiac disease, as Professor Shireen explained before, we need to do anti-tissue transglutaminase test and biopsy. In case of idiopathic hypereosinophilic syndrome, we have to check for peripheral eosinophilia and make sure that the eosinophil count is not more than 1,500 per high power field for the last 6 months. Usually, it has multi-system infection, and it is associated with myeloproliferative disorder. Now we proceed to the lab diagnosis in eosinophilic gastroenteritis. Usually there is elevated absolute eosinophilic count. In mild cases, it's more than 600. In moderate cases, it's more than 1,500. And in severe cases, it's more than 5,000. Also, there is increased stool alpha-1 antitrypsin due to protein loss in stool. There are decreased immunoglobulin levels due to loss of protein. There is increased stool fat. Usually the IgE is elevated, the ESR is elevated, there is iron deficiency anemia, and there is low serum albumin. For the endoscopic diagnosis of eosinophilic gastroenteritis, we might have mucosal erythema, nodular mucosa, friable mucosa, ulcerated mucosa, pseudopolyps, infiltration, villus atrophy, mucosal edema, or fibrosis. Also, we might have normal endoscopic picture, and that's why we have to make sure when we are taking the biopsies that those biopsies are from both normal and abnormal mucosa. There are some limitations of endoscopy in cases of eosinophilic gastroenteritis. Usually, the endoscopy is not sensitive or specific for the diagnosis, because there are many other diseases that share the clinical picture of eosinophilic gastroenteritis. Those diseases include Crohn's disease, ulcerative colitis, lymphoma, and other intestinal and gastrointestinal disease. We have also to make sure that we take biopsies from at least 5 or 6 different sites, as Professor Ng mentioned, in case of eosinophilic esophagitis, because there might be infiltration.
You presenting from your mobile, because we have echo and audience send complaints about this. I have 4 complaints.
Okay, sir. I will just come.
I don't know where you are talking.
Is it okay now, dear Professor?
Okay now. شكرا.
عفوا يا فندم. So we have patchy distribution of eosinophils. So this requires that we take biopsies from at least 5 or 6 different sites from normal and abnormal mucosa, because sometimes the eosinophils may infiltrate the normal mucosa. Imaging has some little role in the diagnosis of eosinophilic gastroenteritis. Usually the CT findings are positive in 40% of the cases. It shows thickened mucosal folds. In complicated cases, it might show strictures, ulcerations, polypoid masses in advanced case. Abdominal ultrasound and endoscopic ultrasound might show mucosal edema. Similar changes are observed in Crohn's disease, TB, and lymphoma. We have a famous sign in the eosinophilic gastroenteritis due to the mucosal edema and the presence of the dye in between those mucosal folds. We have an appearance that's called aranite limb-like sign, which means like it's like the spider legs, okay? Because there is inflammation of the mucosa, and in between this inflamed mucosa, the dye can pass. Regarding the pathology, which is the mainstay of the diagnosis, we can find different pathological appearances, as we can find different endoscopic appearances. We might have crypt hyperplasia, epithelial cell necrosis, villus atrophy, abscess, mast cell infiltrates, hyperplastic infiltrated mesenteric lymph nodes. This is how the biopsy looks like. There is infiltration with the eosinophils. The count of the eosinophils in the biopsy differs according to the site and to the age. For the adult, in the duodenum, the presence of more than 20 eosinophils is considered diagnostic. In the duodenum, in the cecum, more than 40 eosinophils is diagnostic, and in the colon, more than 50 is diagnostic. Regarding pediatric population, for the duodenum, more than 10 is diagnostic, and for the colon, more than 16. Now we will deal with the treatment of eosinophilic gastroenteritis in a stepwise approach. The management depends on targeted elemental diet, medical treatment, treatment of complications, and we will comment on the emerging treatments for the eosinophilic gastroenteritis. First of all, we should use PPI and eradicate H. pylori if present. We can do the food allergy test and use it for targeted elimination diet. In mild cases, we might maintain on targeted elemental diet, only dietary control, and in case of failure of dietary control, we can use montelukast, promogine, or ketotype. In case of moderate cases, we can use montelukast or budesonide. If there is response, we can keep on the same treatment, and if there is failure, we can deal with the case as a severe case. In severe case and failure of montelukast and budesonide, we can start prednisone along with elimination diet. If there is response, we can taper the prednisolone and maintain on budesonide. If there is failure, we can reevaluate the case. If we confirm the case, we can add montelukast and ketotifen to the prednisone. Also, in case of failure of maintenance on budesonide, we can stop budesonide, resume prednisolone, and then add montelukast and ketotifen. In case of response, we can taper the steroids and maintain montelukast. And in case of excellent response, we can taper the steroids and maintain azathioprine. In case of failure, we can stop montelukast and add azathioprine. And in case of failure, we can try anti-TNF and other biological treatments. In case of complicated cases, we can go to surgery, such as if we have stricture. And after surgery, we maintain on montelukast, and if we could not maintain on montelukast, we can shift again to prednisone and targeted elimination diet. The emerging lines of treatment is fecal microbiota transplantation has been used for this condition. It was reported in a patient refractory to enteral nutrition, azathioprine, steroids, and surgical resection. In the end, I would like to thank the society, to thank Professor Serag and Professor Ramadan, and to thank all the audience. Thank you very much.
Thank you so much, Dr. Mohamed, for your presentation. I just want to highlight some points regarding eosinophilic colitis after your talk. And this is as a continue to the case presentation I previously presented. Eosinophilic colitis is rare inflammatory disorder. It is the least frequent manifestation of eosinophilic gastrointestinal disorders, with some overlap between eosinophilic gastroenteritis and colitis. And there is no characteristic clinical picture of eosinophilic colitis. It can present with pain, weight loss, diarrhea, which may be bloody or non-bloody. It may present with malabsorption, protein losing enteropathy, and if the eosinophilic infiltration reaches up to the muscle layer, there may be colonic thickening, colonic perforation, intestinal obstruction, volvulus intussusception, and if the eosinophilic infiltration is up to the serosal layer, there may be eosinophilic ascites, and there's usually history of allergy or atopy and peripheral eosinophilia. Eosinophilic colitis affects both infants and adults, with only characteristic feature being an intense eosinophilic infiltration in the colon that can be segmental or diffuse, and that's why biopsies are mandatory, and they should be taken from normal and abnormal appearing mucosa. At least 4 to 5 biopsies per site. There is no established defined cutoff for the number of eosinophils per high power field to diagnose eosinophilic colitis, making the diagnosis of this entity challenging. Certain cutoffs have been suggested: more than 56, more than 100 in the right colon, more than 84 in the transverse or descending colon, and more than 64 in the rectosigmoid colon. And according to older references, diagnostic threshold is more than or equal to 20 eosinophils. And as Dr. Mohamed Hassan said, there are different cutoffs according to different references, as there is no guidelines till now regarding this entity. Peripheral eosinophilia is common in up to 2/3 of patients. High serum immunoglobulin E is common, and also eczema and atopic disease such as asthma may be accompanied. There is no evidence to support routine food allergy testing, such as skin touch or allergen-specific immunoglobulin E to be used in clinical decision-making, as no food allergy test has been shown to be effectively identifying the specific culprit foods leading to clinical improvement of symptoms or tissue eosinophilia. And the diagnosis is confirmed by an experienced gastrointestinal pathologist to assess if the number of eosinophils is more than expected for a particular area, with lack of involvement of other causes and absence of other causes of intestinal eosinophilia mentioned by Dr. Mohamed Hassan, such as gastrointestinal infections, hypereosinophilic syndrome, systemic diseases, as the inflammatory bowel, celiac, vasculitis, connective tissue disease, and drugs. And this makes the diagnosis so challenging, as no standards exist for diagnosis till now. Regarding the management, and we have a question regarding this point, therapeutic approaches are based on case reports and small case series, as prospective randomized controlled trials are lacking. Although there are no guidelines in this regard, yet steroid treatment is the first option in controlling disease. And the question was about, why didn't we use budesonide at first? Yes, this is true. Alternatively, we can use budesonide, which has been reported to induce and then maintain remission for up to 2 years. But as we know that it is not widely available in Egypt, and also it is costly. Other treatments such as antihistaminics, muscle antagonists mentioned by Dr. Mohamed Hassan can be used specifically in eosinophilic gastroenteritis. Other treatments such as anti-interleukin 5 antibody, anti-immunoglobulin E monoclonal antibody has been tried in a small series of patients. However, none of these agents can be recommended for routine use based on limited available data. And lastly, several reports have described an improvement in disease activity with an elemental or elimination diet. And by this, we come to the end of this session. And thank you for your attention and listening. And thank you, Dr. Serag, again for your invitation. And thank you, all the speakers, Dr. Anji, Dr. Mu'taz, Dr. Mohamed, for your cooperation. And if you have any questions.
Really, we thank you very much.